When you think about what delays a phase 1 clinic, your mind probably jumps to the usual suspects. Maybe it's clinical operations hitting a snag, or a manufacturing delay, or maybe the crow you're working with just isn't available. While those are all valid, what if I told you the real root cause, the thing that secretly unravels your timeline, often starts much, much earlier? It starts with the analytical decisions you make way back when you prepare IND. Analytics. It's not the most glamorous part of drug development, is it? It's not the big discovery or the pivotal clinical result. It just sits there, quietly humming in the background. But don't let that fool you. Analytics is the hidden driver of your timeline. It's the gatekeeper that determines whether your precious clinical material can even be released. It's the foundation that tells you whether your data can be trusted. And when the pressure is on and timelines are tight, it's what allows you to answer tough questions quickly and confidently. Without solid analytics, everything else grinds to a halt. There's a really common and dangerous assumption that I see teams make all the time. They think, analytics can always catch up later. We'll just get the program moving, and we can fix the methods, refine the specifications, or add the right controls once we're already in the clinic. It feels pragmatic, like you're prioritizing speed. But this assumption is a trap, and it's one that can quietly sabotage your entire phase 1 program before it even gets off the ground. So, why is that assumption so dangerous? Because the moment you enter phase 1, the entire dynamic of your program changes. The clock starts ticking louder. Timelines that seem flexible suddenly become incredibly tight. The release of that clinical material becomes the most critical activity on your Gantt chart. Any uncertainty in your analytical data doesn't just stay in the lab. It transforms directly into schedule risk. And once you start slipping, trying to recover that lost time is an uphill battle that you'll almost never win. Now, let's be clear. I'm not saying your analytical methods need to be perfect, fully validated showpieces at the IND stage. That would be overkill. But they absolutely must be reliable. What does reliable mean? It means they have to be good enough to consistently support 3 key activities without constant troubleshooting: releasing your batches, running your stability testing, and most importantly, investigating any unexpected results you might encounter. If your methods are flaky, you're building your program on a foundation of sand. A frequent pitfall I see is teams trying to stretch their discovery-era methods into the GMP world. On the surface, it seems to make sense. These methods worked in the research lab, right? They gave you the data you needed to get this far. But discovery methods are often not built for the rigor of routine testing. They might be operated by highly skilled scientists who can finesse them into working just fine until they're stressed by the real-world pressures of tight timelines, multiple operators, and repeated use. And when a method fails during phase 1, it's not a small problem. Everything stops. Release testing comes to a dead halt. A formal investigation has to be launched. Suddenly, questions are flying from every direction. Is the material bad? Is the method wrong? Was it human error? While your analytical team scrambles to figure out what the data is actually telling them, your meticulously planned clinical timeline is slipping away, day by precious day. That's the real cost of a method that wasn't quite ready. It's not just about the methods, either. The specifications you set also play a huge role. The provisional specs you put in your IND have a direct and immediate impact on every single batch release decision. If those specifications are vague, or if they're based on very limited data and are poorly justified, you create a new problem. Every time you get a result that's slightly out of trend, it doesn't trigger a clear, simple decision. Instead, it becomes a lengthy, painful debate. This ambiguity is incredibly expensive, not just in terms of money, but in time and team morale. When your specifications are fuzzy, it forces your quality and technical teams into making subjective case-by-case decisions for every batch. This is a recipe for slowdowns. It slows material release to a crawl. It creates friction and tension between teams, and it even increases your regulatory exposure, all happening while the clinical timeline is already under immense pressure. Clear, well-justified specifications turn debates into decisions. Your stability strategy also matters more than you might think, even this early. No, regulators don't expect you to have 2 years of long-term stability data for your IND, but what they do expect is that your stability program is designed to produce interpretable data. This means your analytical methods themselves need to be stable over time. If your methods drift, how can you confidently say whether a change you are seeing is in the product or in the asset? A solid, forward-looking stability plan is about ensuring you can make confident decisions down the road. Another area where teams get into trouble is with comparability. It is almost a guarantee that you'll make some changes to your process or formulation as you prepare for and move through early clinical supply. Maybe you scale up the batch size or tweak an excipient. These changes often expose hidden weaknesses in your analytical comparability plan. If you haven't thought ahead about which methods are critical for demonstrating comparability, you can be blindsided by unexpected analytical differences between batches that you can't easily explain, causing yet another delay. So what does this all come down to? It comes down to leadership. Strong analytical leadership at the IND stage isn't about doing everything perfectly. It's about making smart, strategic choices. It's about deciding what absolutely must be solid right now to de-risk the program, and what can safely be allowed to evolve later. And this can't just be a gut feeling. It has to be backed by a clear plan for that evolution. A clear scientific rationale for your decisions, and clear ownership of who is responsible for what. So, what does good look like at this stage? Good IND-stage analytics isn't about eliminating every single risk. That's impossible. It's about preventing the preventable delays. It's about building a robust enough analytical foundation that it enables fast, confident decisions when you get into phase 1, where the timelines leave you very little room for error or uncertainty. It's about making sure your analytics team is an enabler of speed, not a source of bottlenecks. Ultimately, the key takeaway is this. Successful, on-time phase 1 programs are not driven by last-minute heroics or scrambling to fix problems as they arise. They are the direct result of quiet, disciplined, and forward-thinking analytical choices made long before the first patient is ever dosed. Getting this right is one of the most powerful levers you can pull to protect your clinical timeline. Thanks for watching. In the next video, we're going to tackle a counterintuitive topic: impurity data. I'll explain why collecting more data too early can actually make your decisions harder, not easier, and I'll show you how to avoid falling into that common trap. Make sure you subscribe so you don't miss it. See you next time.